Okay, hi everyone. Welcome to the 20th meeting of this Rotary year. Before we start, let's hear the housekeeping rules from Klaus.
Sergeant at Arms Klaus, please.
Buenos tardes. Good evening, President. Good
Good
evening,
evening.
fellow Rotarians and guests. Welcome, our guests.
Good evening.
The best regards from Cordoba in Spain.
Whoa.
Wow.
Please keep your video switched on so we can see you all the time. And this session will be recorded for our club promotion. And during the session, you are all muted and you can use the chat function to communicate with other members. And at the end, there will be the question and answers. Please raise your hand in the Zoom function and you will be invited to talk. So I all wish you a very wonderful Rotary meeting. Thank you.
Thank you.
Thank you, Sergeant at Arms. I shall now share the next slide. May I invite our Toastmaster this evening to raise a toast to Rotary International and also to our visiting Rotarians, if any.
So, yes. So, President Lewis, it's my pleasure today to raise a toast to the Rotary Club of Reservoir Hills in District 9370 in South Africa. The club was chartered on 27 March 1995, and they hold their weekly meetings every Wednesday too. We are pleased this evening to have Ratan Charlie Pandey, Rotarian Charlie Pandey, who is a past president and is visiting his relatives in Singapore and currently in quarantine. Past President Charlie Pandey was instrumental in securing hospital equipments for the physically challenged. Fellow Rotarians, please join me in a toast to the Rotary Club of Reservoir Hills, coupled with a toast to Rotary International.
Rotary.
Yes.
Rotary.
Rotary. All right.
Hi.
Thank you, Rotarian Anita, who is one of our newer members, recently inducted. Thank you very much for taking up this challenge to be the Toastmaster.
Thank you. Thank you, Mr. Lewis.
And now, so we have in our house, Dr. Rupesh. Is he here this evening? Dr. Rupesh was re-inducted last week and it is his birthday. We also have Rotarian Vinit Saranga, but he said that he may not join us because he's traveling in India now. But we wish both of them all the very best and well wishes for their birthday. And for wedding anniversary, we also have Vinit and Tajali Saranga for today, 17 November. We also have Anj and Vandana, Manish and Nandita for 21st of November. And our Sergeant at Arms, Dr. Klaus Dusman and Swee on the 23rd of November, followed by Honorary Member, Past District Governor, Dr. Ivor and Maureen Tavatasan for also 23rd. So we wish them all the best and heartiest congratulations to all. I would like now to call upon Membership Director, Rotarian Subhash, to share with us a little bit about our very talented musicians who will be inducted this evening. Rotarian Subhash, please. You are muted, Subhash.
Thank you, Rotarian. Thank you, President Lewis. I'm really honored to today introduce Mathias Bergner. I hope I'm pronouncing it correctly. He will bring the great music to this club, which is, Mathias is primarily a musician. Excellent, it's like virtuoso, or you say the great musician in the violin. And he has been, he's born in Munich, and he's born in Munich. He's Swiss or German national, and he was inspired by, in Switzerland, some of the Thai monks or Thai people. So he moved to Thailand, and after that, he's been in the region for so many years. He has worked in China. He has worked everywhere. He has performed in the Hindu temples, Buddhist temples, and a lot of things. So he's more spiritual plus musician. I think he's a combination. He's kind of a person who really Rotary will admire and help. Now, Mathias is settled in Singapore. He was earlier a full-time member of Rotary Club in Switzerland. So he knows what is Rotary. So I'm sure we will welcome him in Singapore and in our club, and he will bring a lot of, I'm sure one of these days we'll have his personal solo performance also, and see how we can get benefit his musical talents. Thank you, Mathias.
All right, thank you, Rotarian Subhash, Director of Membership. And many of you who are prospective, you will, of course, be meeting up with Rotarian Subhash a lot, and he will also be introducing you in time to come. But for this evening, it is our great pleasure to introduce to you our new member, Mathias Bergner. Fellow Rotarians, it is my privilege and pleasure today to welcome into our membership Mr. Mathias Bergner, who was proposed for membership by our Sergeant-at-Arms Rotarian Klaus Dosmond. The proposal has been reviewed in accordance with the Constitution and bylaws of the club. Mathias, as you would like to be called in the club, we now proceed to admit you into membership. You have chosen for membership in this club because your fellow members believe in you to be a leader in your field and have qualities which will allow you to carry out the work of a Rotarian. In electing you to membership, we are doing more than taking you into our fellowship. We are making you a trustee with us of Rotary's ideals. Knowing you to be a Rotarian, the world will henceforth judge Rotary by your conduct. Membership in Rotary is an honor and privilege, and of course, every privilege has its corresponding obligations. We have agreed to accept the responsibilities attached to your membership in this club and to obey this club's constitution and bylaws. And one of the special obligations is regular attendance at our weekly meetings and also monthly service committee meetings, and to participate in club projects and activities. The primary method of fulfilling the principles of service and fellowship, and also by way which you represent your vocation, is through participation. Mathias, the ideal of Rotary is service, and our motto is service above self. Object of this club and all Rotary clubs in the world is to encourage and foster this ideal of service above self as a basis of worthy enterprise, and we would like you to share in this effort. For the rest of this Rotary year, I will be pleased if you would serve on the Vocational Service Committee under Director Sonali, and you will be mentored by, who will also be your mentor, Director Sonali will also be your mentor and guide, and your classification will be education, music. As you represent education and music, it is your duty to tell us about your vocations and to bring the ideals of Rotary to your education and music professions. And now, by the power vested in me as President of the Rotary Club of Singapore, I declare you to be an active member of this Rotary Club. I will present you with the Rotary emblem and Rotary literature, I hope next week. I especially commend to your attention the object of Rotary and the four-way test, which form the criteria for Rotarians in their daily lives. I also suggest that as and when you are overseas, please attend the meetings in those countries that you're at, or the cities or the towns that you're at, so that you can also partake in their fellowship, because this is another rewarding benefit of Rotary membership, international organizations. Fellow Rotarians, I'm now happy to present to you Rotarian Mathias, our newest member. Please warmly welcome him to the Rotary Club of Singapore, which is the oldest and biggest club in District 3310. Please unmute yourself and let us give a warm and rousing welcome to Mathias. Welcome.
Welcome, Mathias.
Welcome.
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 Mathias, can I invite you now to say a few words?
Yes, dear presidents, dear, may I say, fellow Rotarians now, this introduction has moved me very much. I'm impressed how you characterized me. I think I have, this is the first time I experience it like this. And I wish to thank you all so much. Of course, President Louis, my proposer Klaus Dusemund, Suresh Kerti, Bernie Ng, Jessica Lim, Rotarian Subash, and all. Yeah, forgive me if I don't mention more names. I had this idea. I would like to share one piece of music with you. If that's okay.
Yes, please. Yes, please.
It would last 2 minutes. It's a short piece, a famous piece. I hope it works with the Bluetooth, so I will try this. Yeah, so we'll see. The Swan by Camille Saint-Saëns. Thank you.
Well done.
Very
Thank
good.
you very much. It's very uplifting.
Thank you.
Thank you very much.
Thank you. Thank you. Thank you.
A very novel introduction of yourself. Thank you very much. We already can see how much you will be contributing to the Rotary Club.
I will try my best. Yes.
Thank you so much. Yes. Okay, I will now move to the next segment of the meeting. And this is the Fireside Chat for this evening. And with us this evening, we have Professor Teo Yik Ying from the NUS Swee Hock School of Public Health. And the moderator for this evening will be Dr. Suresh Mathani. So I will call upon Dr. Suresh to now do the introductions. Dr. Suresh, please.
Thank you. Thank you, President Luis. I would like to introduce our eminent speaker for this evening, Professor Teo Yik Ying, who is the Dean of the Swee Hock School of Public Health at the NUS. Prof Teo completed his bachelor's program in mathematics in Imperial College, followed by a master's in applied statistics at Oxford University. He then went on to do his doctoral training also at Oxford, majoring in statistical genetics. He continued with his postdoctoral training with the Wellcome Trust Center for Human Genetics, where he was also appointed at the same time as a lecturer at the Statistics Department in Oxford. Now, Prof Teo has also previously served as the director for the Center of Infectious Diseases, Epidemiology and Research in Singapore, which works to develop capabilities for disease surveillance, consultation, and research to deter and control potential infectious diseases outbreaks. He has had a very illustrious career. For his contributions and achievements to academia and public health, Professor Teo has been the recipient of numerous awards. Now, without further ado, I would like to request Professor Teo for his presentation. Thanks. Professor Teo.
Thank you very much, Dr. Suresh, and thank you once again to all of you for inviting me to join you in your meeting today. I thought it's a very challenging topic that was given to me to talk about really the ethics of vaccination for COVID-19. I think what I would be saying reflects my own views, and they are in no way representative of the Ministry of Health, of National University of Singapore, or of my School of Public Health in NUS. Because I think there are no straightforward answers in some of the questions that I believe you have. And I think over the next 45 minutes or so, we can hold an open and frank conversations, particularly around the situation of vaccination and the ethics of vaccination and some of the measures that we put in place that requires the proof of vaccination. I thought it's important to start off by really highlighting what's happening globally, because worldwide, I believe many of you would have followed the news to see that there continues to be quite a surge in infection numbers, even in jurisdictions and countries that are very well vaccinated, particularly in Europe and in North America. And we start to see that it's not just the infection numbers that have been rising, there's a corresponding rise in the number of hospitalizations in some of these jurisdictions. But at the same time, I think we also see that the statistics that we observe around COVID-19 infections continue to be very low when we talk about countries on the Africa continent or in South America. And it's not because COVID-19 has actually skipped this continent or these countries, but really it has to do with the disparity worldwide in terms of testing capabilities. So sometimes when we see that particular countries, the numbers look very positive, look very encouraging, or it look like they have been managing COVID-19 well, I urge you to also think about what has been happening in that particular jurisdiction when it comes to testing and testing capabilities. Because in many countries now, they are pivoting away from the use of what we call the PCR testing to what they apply in terms of rapid antigen test, or in Singapore, we call it the ART test. If you're using ARTs, positive results from ARTs are not actually reported in the daily case counts in any countries. So I think that is something for us to think about. Now, let's look at the global vaccination rollout. And this actually maps very closely with testing capabilities. And we continue to see huge inequities in vaccination in the Africa continent and in Latin America. And even when we start to talk about countries that are able to vaccinate their people, there are disparities in terms of the vaccines used. So the vaccination policies do differ considerably. in Singapore, we have been very privileged to have a universal policy. And it's not just universal, we even have booster policies in place. And this is very similar to a number of advanced economies. In fact, the US CDC just recently announced that they will have to boost everyone in order to avoid additional pains from COVID-19. In lower and middle income countries, they are actually not that fortunate because their vaccination policies actually have to prioritize frontline workers, some of the clinically vulnerable people, or the elderly. It is not universal at present. It's not just the policy itself, but also the delivery of the vaccines continue to be inequitable, despite many national vaccination policies are specifically designed for equality in terms of giving everyone equal right without payment to access some of these vaccines. In Singapore, I'm quite pleased to share that our vaccination policies are not just designed for equality, but actually we make an effort to strive for equity. And how is this performed? Because not just we have 34 vaccination centers that people can come forward for vaccination. For some of the homebound and bedbound people, there are mobile teams of doctors and nurses that actually visit people in their homes to deliver the vaccines. This is actually something that many countries struggle with because there are always that 10 to 20% of the population that are hard to reach. And even if the national vaccination policies are designed for equality, the actual implementations are sometimes difficult to achieve the objective of equity. Now, let's also have a very short discussion around what vaccination actually means. Because by now, I hope people here will understand that vaccination at this point, when we think about the effectiveness, the efficacy of vaccination, it actually means that we're protecting people against severe disease and against deaths. But it's confusing because some countries, including Israel, look at vaccination efficacy from the perspective of actually preventing infections. And that is why in the public, there's still this confusion. When we talk about effectiveness of the COVID-19 vaccines, people constantly still harp on the fact that I'm vaccinated, but I can still be infected. So is the vaccine actually working effective or not? Now, I think it's important to highlight globally, there's a shift in our policies focusing on vaccine differentiated measures. And I think that would be the topic we'll be discussing quite a lot today. Because when we look globally, the permission to resume travel is a lot centered around allowing people who are fully vaccinated to travel. Domestically, we are starting to see that there are social economic activities, whether it is the opportunity to work, whether it is the ability to actually go on public transportation. This is it's given only to people who are fully vaccinated, and people who are unvaccinated are starting to find there are specific restrictions, such as in the United States, that bans them from working in particular sector, such as in France, that actually ban them from taking public transportation. And in Singapore, we start to see that fully vaccinated people are permitted to engage in a wider range of social and economic activities, whereas those that are unvaccinated are not permitted. And at this point, I think it's perhaps useful for us to focus our definition of unvaccinated people to those that are medically eligible for vaccination, but chose not to be vaccinated. Because I know that there is a very small group of people who are medically ineligible for vaccination. And in Singapore, we do treat them differently from the unvaccinated by choice. So I think moving forward for today's discussion, I would use the phrase unvaccinated people to refer to people who choose not to be vaccinated by choice. Now, I think there are complexities in enforcing some of these vaccine differentiated measures because globally, there are different vaccines being used. There are different standards and accreditation that is necessary. And in terms of assuring that the vaccine that some of these incoming travelers have received are of the right quality? How do we trust the vaccination, the test certificates that travelers come with? In fact, when I travel to the United States, how would the jurisdictions in the United States recognize the vaccination certificates that we have in Singapore? I think some of this data interoperability between systems will need sorting out at the global level. There are certainly ethics with regards to allowing cross-border travel, particularly between people from the advanced economies to the low and middle income countries. Because, for example, I love trekking in Nepal, but is it ethical for me, who is highly well vaccinated and well boosted, to be traveling to a country where the majority of the people are actually not protected by vaccines? And yet, I could be infected when I travel. But because I'm protected by the vaccine, I may not have very strong symptoms that warns me against travel. But in the low and middle income country that I visit, I may actually be spreading and transmitting it to the people who are very kindly hosting me to their country. Similarly, there are ethical issues in terms of denying work, schooling, leisure, and healthcare. But equally, we could have a debate about is it ethical to deny? And similarly, is it ethical not to deny? So I will just stop at that, and I look forward to some of the questions and discussions that we will have today. So over back to you, Dr. Suresh.
Okay, thank you, Prof Teo, for your presentation. We do know that COVID mRNA vaccine is very effective in reducing the transmission of the Alpha variant, but it is unclear if they can actually stop the transmission of the current Delta variant. Now, as you had mentioned, Israel's data suggested that those vaccinated in January 2021 could have as little as 16% protection against the disease in July this year. Locally, the mRNA vaccines have been found to reduce the risk of any infection by the Delta variant by as little as 40%. However, the risk of severe disease is reduced by around 90%, even in the absence of booster injections. So my first question is that if the vaccinated are allowed to roam free with the COVID passport, and we restrict the movement of the unvaccinated, wouldn't that be considered as discrimination, especially since the vaccine does not significantly reduce the transmission of the Delta variant?
Thank you very much for this question. And I think it may be useful to start off with one fact, which is even if a country or a city is able to achieve 100% uptake of the vaccine, we will continue to see COVID-19 being transmitted in the community and being circulated in the community, because the Delta variant is that much more transmissible. And I think that is the reason why countries worldwide are pivoting away from this zero COVID strategy, except for China and its jurisdictions and cities that it's under its control. The reason why we think that zero COVID will not work, it's because it is no longer possible to stop the transmission of the Delta variant in the community. So that's just one fact that we should remember. So even if everyone in the country is fully vaccinated, we will continue to see the disease circulating. And it is equally true that the vaccine does not prevent the transmission. So people who are vaccinated will continue to be infected and will continue to transmit, even though the risk of infection and transmission is believed to be lower compared to the unvaccinated. But I think one thing that is very true is that what you have mentioned, that fully vaccinated people will enjoy a significant degree of protection against severe disease and death. And in Singapore, in Germany, in the United States, in Israel, there are very consistent results to suggest that the vaccinated people are between 10 to 14 times less likely to suffer from severe disease and death when infected. So I think on the basis of this, the question is really, what should a responsible government be doing? And in my opinion, a responsible government could think about the following. The first is that it tries its best to procure and then to offer highly effective vaccines to as many people as possible in the population in a manner that doesn't discriminate or differentiate social, economic, financial status of the individuals. And I talk about having of people to bring the vaccination to the people who are unable to access some of these vaccination centers. The second is, how do we minimize the risk of exposure to the unvaccinated people, given that we know from the data that these are the people that suffered the brunt of severe disease and hospitalizations in the event that they're infected. And the third is that we know that it is not possible to maintain a zero COVID stance now. And economically speaking, it is also not practical. So if those are some of the realities that we will relax our measures to allow economic activities to resume. When that happens, transmission in the community will increase, just like what we are seeing in Singapore over the past 2 to 3 months. We have hundreds and then we have thousands of cases in a day. But when we have that, is it actually right of a responsible government to say that we allow the unvaccinated people the same degree of mobility, given that we know that they will bear the brunt of severe disease and death? And I actually think that a responsible government will not do that. And we're starting to see many countries actually putting in place some of this so-called vaccine differentiated measures. Austria, for example, this week, I'm sure many of you would have caught the news that they've actually put in place very strict restrictions not to allow unvaccinated people to move about in the country. And I should mention that this is not just in Austria, in France, in the United States, we've also been seeing reports of this vaccine differentiated measures. And these are what we typically would consider as liberal democratic countries. Internationally, countries realistically, operationally are requiring travelers to be fully vaccinated, despite what the World Health Organization have been talking about. So I think these are some of the realities we are seeing. And it's not just Singapore, it's happening in many countries, many jurisdictions. And I like to think that it is not a form of discrimination, but it's a form of specific protection that is given to the unvaccinated people. Because is it actually right for a responsible government to permit unvaccinated people about freely when we know that they are 10 to 14 times more likely, when infected, to be entering hospitals and potentially die from it?
Thank you. Okay, I've got another point that I wanted to discuss. Now, in Singapore, children under the age of 12 will be authorized to get the vaccination early next year. Now, they are considered as low risk, but the vaccination is being advocated clearly in the interests of the unvaccinated seniors. Now, if the vaccines are completely risk-free, then mandating them will be very reasonable. But we do know that the vaccines do carry a small risk of myocarditis in the young. Now, myocarditis is actually an inflammation of the heart, but such risks become more significant for groups who are already at very much less likely to develop complications from COVID, such as the young. So, is it reasonable to vaccinate this group of people?
I think this is a question that has been very popular in recent days, because I think it was just a couple of days ago that our Minister of Health, Minister Ong, actually talked about vaccinating children. I think perhaps I could first start off by addressing the perception that there are low-risk groups for COVID-19. Children, young adults are often believed to be at lower risk of complications in the event of COVID-19 infection. And the data, the statistics do suggest that this is indeed true. But I think it's important to compare the risk here, because otherwise it is very easy to talk about different risk without really understanding to what degree is one much more likely to happen than the other. So earlier on, Dr. Suresh, you talk about myocarditis, and actually it's not just myocarditis, it is also pericarditis, which is the inflammation of the lining around the heart. And generally people with pericarditis, when they have difficulty breathing deeply, it's a sharp pain near the parts of the heart. So according to the US CDC, the US Center for Disease Control and Prevention, the rates of myocarditis and pericarditis for people who have received the second dose of mRNA vaccine. And over here, I talk about individuals between 12 and 39 years old. So generally older children, adolescents, teenagers, and young adults. We still do not have the statistics for young children below 12 just yet. But for this group of people between 12 to 39, myocarditis and pericarditis rates are about 12 to 13 cases per million doses of second dose vaccine, of the mRNA vaccine. So it's 12 to 13 cases per million doses. Remember this number, 12 to 13. Now, international data presently suggests that for children between 0.3% to 0.7% of children, when they're infected with COVID-19, will experience severe illness and require intensive care. So I think we need to translate this to the per million statistic. So we are talking about between 3,000 and 7,000 per million infected children will experience severe illness and require intensive care. Now, granted, children are less likely to be infected. So earlier on, Dr. Suresh, you introduced that I'm a statistician. So I like to also look at the probability and the risk very carefully. So in Singapore, children below 12 years old actually account for about 6 cases out of every 1,000 cases. If we combine some of these numbers, I won't bore you with the mathematics, but if we look at the local data, we are still looking at between 18 to 42 per million children will suffer from severe illnesses. Earlier on, I talked about the rates of myocarditis and pericarditis is between 12 to 13. Let's say 13. Let's take the upper bound here. But for children suffering from severe conditions of COVID-19 infection, it's between 18 to 42 per million. So potentially about 3 times more than the risk of pericarditis and myocarditis. And this is on severe illness requiring intensive care. Let me now talk about the risk of long COVID. And long COVID is defined as people who have been infected with COVID-19 and who continue to suffer from symptoms up to 15 weeks and beyond post-infections. Because most people, after about 2 weeks of infection, they're actually fine, they return to normal, and generally there's no long-term symptoms. But a percentage of the people will experience what we call long COVID. And long COVID is actually much more prevalent for people who are unvaccinated. Let's look at children between 11 to 17 years of age, and this is where data from the UK comes in, is actually 1 in 7 children, or about 14%, who have been infected with COVID-19 continue to have symptoms beyond 15 weeks. So the question that I have really for parents who are hesitating to give their children the vaccine is, what is the alternative here? If there are alternatives where the risk of myocarditis and pericarditis is 0, then clearly those will be very viable alternatives that parents would be looking at. And that is where perhaps Novavax, Sinovac, some of these vaccines that are not mRNA will be possible vaccines for parents to take, to give to their children. And over here, I'm recommending that parents ought to vaccinate their children. But the pediatric data from Novavax, it's not available just yet. I believe it will come in later. So Singapore is still evaluating some of the data from Sinovac for pediatric cases. So I think in the meantime, the question that parents have to think about is, do I leave the kids unprotected, especially when Singapore is opening up in a big way? Or is it ethical then to leave kids unprotected when actually there are effective vaccines, where if you talk about the risk or the cost to the benefit, at present, the data clearly suggests that the benefit still outweighs the risk. And there are many factors, there are many actions and steps that are taken by the Ministry of Health to actually help to reduce the risk of some of these adverse side effects as well. So I think those are some of the questions that I don't have answers for individual parents, but I do ask them to think about what is the alternative? Would you be leaving your child unprotected in a world in Singapore, or if you travel overseas, where the risk of infection and of severe disease is indeed going to be much higher than the risk of myocarditis and pericarditis from the infection, from the vaccination?
Thanks. Well, Prof, another question would be that if the senior citizens are actually more prone to becoming seriously ill compared to the younger population, shouldn't the vaccine passports be more appropriate only for these seniors, as they are the ones who would most likely benefit from them?
So I think this ties in with the earlier conversation about the misperception that only seniors are more prone to become seriously ill when infected. I like to remind people that based on the statistics that we have locally, I don't even need to look at international statistics. For unvaccinated people, 1% or 1 in 100 people of those between 20 to 29 will develop severe disease to the point that they require oxygen supplementation. So 1%, or effectively 10,000 out of 1 million people. And that is for 20 to 29. If I look at 30 to 39, Singapore, our statistics is 3% or 3 in 100. For 40 to 49, this rises to 5%, 5 in 100. For 50 to 59, 13% of the unvaccinated people will develop severe disease to the point that require oxygen supplementation. And that is actually quite serious. So I think that is a very important fact that we have to remember. It is not just the seniors that benefit from the vaccination. And I think there's this misperception that's going around. And the fact that you ask today, I think that's a great question, because I have this chance to clarify. Importantly, earlier on, I talked about the problem of long COVID for children between 11 to 17. Let's talk about long COVID in adults, young adults, and generally elderly adults. It's upwards of 1 in 5, meaning more than 20% of the unvaccinated people will experience some form of long-term symptoms after they've been infected. So I think it's important to correct the misinformation here, that it's actually not correct to think that younger children or younger people, younger adults can get COVID-19 and not suffer from the infection, that vaccination really only benefit the elderly. I think this is absolutely wrong. Local international data clearly shows that everyone of every age group benefits from the vaccination.
All right, thanks. Well, actually, another interesting point I would like to touch on is responsibility. Now, it's already mandated that from the 8th of December, COVID-19 patients who are unvaccinated by choice must pay for their bills incurred at hospitals and COVID treatment facilities. So it is the individual's responsibility to bear the consequences of not getting vaccinated. So then what about people who indulge in smoking, binge drinking, overeating, or not practicing safe sex, they should also be held responsible for their actions and their lifestyles. So shouldn't they also be penalized by having to pay for their hospital admissions if they fall ill as a result of their vices? Can
Absolutely.
I have a comment? No?
Absolutely. So I'm definitely in favor that people who smoke, who lead generally an unhealthy lifestyle, binge drinking, unsafe sex, I think these are the people that will be paying for their own medical expenditure, because in Singapore, actually, they have to co-pay when they are hospitalized for any of this condition. They do not receive free healthcare. Now, there's this imbalance that people are starting to draw the parallels against, but actually this parallel is wrongly drawn, because we started off giving people completely free COVID-19 treatment. And this is a luxury way beyond what we talk about in terms of co-payment or subsidized treatment. So right now, we are saying for the unvaccinated people, we will treat you exactly as if you are smoking. You have to be hospitalized because of smoking problems, because of obesity-related problems, because of binge drinking or unsafe sex problems. Effectively, you are eligible for subsidized healthcare on the basis of whether you are a citizen or a permanent resident. But at the same time, you have to pay your fair share of the healthcare that you experience. So right now, for the unvaccinated people, we have given them the privilege that is similar to people who would normally be engaging in whatever lifestyle that requires hospital care subsequently. We have just taken away this additional privilege that was given to everyone previously for completely free treatment against COVID-19. So I think when we start to draw parallels against other unsafe behaviors, it is important to remember that when we treat people for smoking-related problems, let's say lung cancer, a person equally will have to foot their co-payment bills. They will be eligible for subsidy. They will be eligible to use their free M, MediSave, and MediShield insurance. And they have, of course, the subsidies I talk about. So when we start to think about, are we penalizing the unvaccinated people? You can now actually turn it around and say that we are putting in place a system where vaccinated people, the government is actually coming in to foot their bills completely. And I think it's also important to highlight that you talk about unsafe behaviors. Actually, for people who engage in unsafe behaviors, such as smoking or high obesity, they've been penalized through higher insurance premiums anyway. So at this point in time, I think it's important to come back to the guide.
Whether you want to hear, but I'll put this.
I think it's important to come back to Singapore's guiding principles in healthcare since Mr. Lee Kuan Yew's days, that it has always been founded on the basis of co-responsibility. So individuals play their part, government play their part to provide the safety nets and to provide subsidized medical care. So I think it is actually not appropriate to compare getting vaccinations with issues such as obesity and binge drinking. And especially since the burden of harm from actions such as obesity, binge drinking, tend to fall mainly on the individual themselves, with very little harm to other people. And I actually guess that over the next 12 to 18 months, almost everyone in Singapore will be exposed to the coronavirus. And for anyone unvaccinated, it is with some degree of certainty that the person will be infected over the next 12 to 18 months. Now, if we know that this is almost certainly going to happen, what would a responsible government do? And we talk about fairness and ethics. I could easily turn the question around and ask, is it then fair to think about getting taxpayers' money from people who have dutifully taken up their vaccine? And this is about 95% of all eligible people now. This 95% of the people end up having to pay and subsidize the healthcare of the remaining 5%, simply because the 5% decided they will not take the vaccines, despite very clear evidence that they are disproportionately more likely to require hospital care when infected.
Thank you. I'm going to take some of the questions from the fellow Rotarians. Brock, his question is, I've read that the vaccination certificates only last for 1 year. Is this correct?
Well, to be honest, I think this is what I would consider one of those storm in a teacup thing. And I actually reflected it back to some of our colleagues at Straits Times that we need to address this very clearly, because this is a very new vaccine that the world is seeing and is being introduced to. And every time that we have a vaccine that we do not know for sure what is the length of its validity, or if we know that the protection that it confers will wane with time, we will put a timeline and expiry date to it. So if you have taken the yellow fever vaccination before, you will know that it lasts for about 10 years. For COVID-19 vaccine, because it's new, the information that we have around this is actually not very well established. So I believe the Ministry of Health actually just tagged a 1 year validity to it, with the intention that they will revise this validity with additional information. And actually, right now, given that we have already talked about and in the process of giving people booster shots 6 months after their second shot, I personally felt that this worry about a 1 year expiry is unnecessary, because clearly we are actually telling people that 6 months later after your second shot, please come in to get your third booster shot. So in terms of whether we will shift the definition of fully vaccinated to free shots, I actually think that that will come soon. Maybe in a few months' time, once we have the confidence and better information, and of course also have given children the chance to be vaccinated, we may actually shift the definition of full vaccination to 2 doses for certain age group and 3 doses for other age groups. What would be the validity for 3 doses then? Again, at this point in time, I don't think we have sufficient information just yet. And it's important to remember the effectiveness of an influenza vaccination is actually around 6 to 12 months, depending on whether you experience the disease from both northern and southern hemisphere. Some people actually may need to take the influenza vaccination twice in a year to be at least well protected against various strains from different parts of the world. So for COVID-19 vaccine, I honestly do think that we don't need to worry too much about this 1 year expiry date at present, especially if we are already giving people the booster shot 6 months after. And at this point, I also would like to encourage people who are eligible for the booster shot to please come forward to take your booster shot.
Thanks. Peter Brock has got another very interesting question, and he is asking, when should we stop publicizing case numbers, as the continued focus on numbers seem to contradict with the message that we aren't chasing a zero COVID outcome?
Thank you very much to Peter for asking this question. And personally, I'm very much in support that we should have stopped publishing daily case numbers a long time ago, perhaps a couple of months ago. And we have submitted our recommendations for considerations, because I do think that telling people the daily case numbers just strikes unnecessary fear in the people. And it also results in a different perception of the disease. Equally, I think we continue to publicize what are the daily death numbers as well. It's a difficult balance to strike, because some people would say that by doing so, the government is being very transparent with the public rather than hiding these numbers in websites and not broadcasting it. But I personally feel that when you broadcast death numbers this way, you actually send a very wrong impression around COVID-19 deaths. And the reality is that we've never talked about deaths from other conditions the way that we talk about COVID-19 deaths, such as daily, actually, we experience about 14 to 15 deaths from cancers, 11 to 12 deaths from pneumonia on a daily basis on average. But we never broadcast these numbers on a daily basis. Maybe if we have done that, people will be much more aware of health-seeking behaviors to go for their regular health checks, to go for their vaccinations against certain types of cancers and so on. But precisely, we don't want to strike fear and to always have this environment and atmosphere, this culture of fear against health conditions. That's why we never broadcast death that way. At the same time, we also shouldn't be broadcasting COVID-19 deaths in this way. I believe we will move towards that. I hope we will do that sooner than later. But at this point in time, it appears that the Ministry of Health, it still prefers to adopt a more transparent approach to let people know what is the current situation, particularly with respect to death numbers.
Thanks. There's another question from Christy. It's with regards to the mRNA technology. And she's asked, mRNA is a new vaccine technology, and we don't have long-term data. And children, as well as for children, we would appreciate the professor's view on this.
So I'm not actually a vaccine expert. And so I may not be as qualified as some of my colleagues like Professor Wee Eng Yong or Professor Swee Yang, who will be much more capable of answering this question. But I will nonetheless, I will give it a go. I will attempt this. Forgive me if I'm unable to provide very strong scientific answers. What do we think about mRNA as a new technology for vaccines? Actually, it's just from the perspective of vaccination. But actually, the mRNA technology has been around for quite a while. And it is not due to very rapid advancement of some of the research that we have put in place in the past, in the first 12 months, ever since COVID-19, that suddenly, in a matter of 6 months, we actually have mRNA vaccines that can enter clinical trials. The technology has always been there. Now, let's address this bit about safety. mRNA vaccines do not remain in the body. So there's all this hyped up fear around whether it will change our DNA structure. It doesn't. It actually degrades with time. So it is actually safe for children and for adults. I have 2 children. One is 13-year-old who has been vaccinated the moment vaccination is permitted for 12 years and above. The second is 11. I will be vaccinating my child with an mRNA vaccine, the 11-year-old, when it's available, because I've been looking at the data and I'm assured that it is safe. And it is not a matter that we have rushed the development of this vaccine in order for it to help to protect the world against COVID-19. mRNA technology has actually been around for a long time. And that's the reason why we are able to repurpose this technology for a COVID-19 vaccine. So I think that's my answer. And I do encourage you to actually look on, I think Professor Wee Eng Yong have spoken on this on webinars that are publicly available on YouTube and actually on Straits Times and on Channels News Asia as well. So you could see Eng Yong's response to this, which will be much more scientific and hopefully more reassuring. But from my basis, I see it as safe enough to vaccinate my own children. So that's my perspective of it.
Thanks, Prof. I've got 2 questions, one from Jacqueline and another one from Louisa. This is with regards to the booster injections. Now, Jacqueline has this to say. 2 days ago, Straits Times reported 72% further reduction in infection risk by 72% for taking Moderna booster shot after 2 doses of Pfizer-BioNTech. What are your comments for the booster shot for Sinopharm? That's the first part. Then another question that was asked, Prof, what is your opinion on people taking a vaccine cocktail? Example, a combination of different vaccines. Apparently, studies have shown greater efficacy.
So this is the taking a cocktail of vaccines has been, that's what we practice in certain infectious diseases. But at present, I think the data on COVID-19 vaccine is actually not that mature just yet for us to be thinking about a cocktail of vaccination of different vaccines. Now, and of course, in other infectious diseases that I talked about previously, the heterologous use of vaccination, of different types of vaccines, actually has been found to be better, to be more effective. Now, Jacqueline's question on booster injections, whether Pfizer, Moderna, or Pfizer, because I believe it was a 72% versus about 60 over percent. I think it's 62%. So the difference was in about 10 percentage point. I personally took Pfizer. My booster shot was Pfizer. My first 2 shots was Pfizer. My booster was also Pfizer. But equally, I have a number of colleagues who actually took Pfizer, Moderna. If you look at the statistics, 62%, 72% against infection. That 10 percentage point depends on your view of it. Actually, my main concern about the vaccine is protecting against severe disease and deaths if I'm vaccinated, when I'm infected. It is a bonus, of course, to be able to protect against infection. But I think the main objective when we think about the COVID-19 vaccine is really to try and protect against the severe consequence of an infection. I would say that if you are eligible for your booster shot, if you have taken 2 shots of Pfizer, then you can consider sticking to Pfizer or switching to Moderna. My understanding anecdotally is that people who have taken Pfizer, and then Moderna will suffer a little bit more from the expected side effects, meaning lethargy, maybe aches, maybe fevers, maybe headaches. These are your expected side effects. These are mild side effects that typically go away after 24 or 48 hours. But otherwise, Pfizer is just as good. And I would also like to highlight that this is what I always mention in international meetings. It's a first world problem. It's a first world privilege in Singapore that we can worry about, should my booster shot be Pfizer or Moderna? When there are many countries that are receiving slightly less efficacious vaccines that are not the mRNA vaccines, just because they are much more affordable. There are many countries that are struggling to even get the first dose in for the frontline people. So it is really a first world problem that we think about. Should I be taking Pfizer or Moderna for my booster? My personal recommendation is they are both as effective on the basis of protecting against severe disease and death.
I hear from my fellow colleague, from my other doctor friends, that there is a huge demand for a booster jab with Sinovac or Sinopharm. Somehow or other, they tend to feel that that might actually be a better option than just taking mRNA vaccination all the way. Your comments?
So my apologies to Jacqueline, because I think I missed out this point that Dr. Suresh actually did mention, that your specific question was around booster with Sinopharm or Sinovac. At this point in time, I don't think we have sufficient data to look at applying a booster with Sinopharm or Sinovac. But the present data is the opposite, that if you have taken 2 shots of Sinopharm or Sinovac and then boosted with an mRNA vaccine, we've seen that it's generally safe and effective. We haven't actually had sufficient data to inform us about the opposite, which is Pfizer or mRNA, followed by an inactivated vaccine such as either Sinopharm or Sinovac. So I'm afraid I'm unable to comment or make any recommendations on that basis. But it's important to also remember at the end of the day, what is the objective here? If our objective is actually to minimize disease and deaths, clearly the mRNA vaccines do present very clear evidence on that. And at this point in time, I think it's also important to mention to people that there's this impression that I should try a variety of, or what you call a cocktail of vaccines in order to increase my protection against COVID-19. What is likely to happen to allow countries, not just Singapore, to really live with COVID-19 in a sustainable and long-term fashion is going to be vaccination, booster, and actually natural infections. Because natural infection is the one that will provide an all-encompassing immunity for perhaps a certain degree of time, but that degree of immunity is believed to be much more powerful than actually the vaccine's protection. So in Singapore, in many countries, we are starting to see that this is likely to be true, that we will need a certain degree of infections happening to the population in order for us to transit safely and sustainably to live with COVID-19. So there are jurisdictions and countries that are like Singapore, meaning places like Australia, New Zealand, Taiwan, Hong Kong, China, that have done extremely well in keeping COVID-19 out of their cities for the longest time possible. And right now they are vaccinating their people in a very big way. But my fear for these places is that they will experience the same degree of surge that we see in Singapore as a result of transiting to COVID-19, simply because the population doesn't actually have a base degree of immunity that was built up from natural infections. And I actually do believe that this base immunity from natural infection is what is necessary, because we have seen that throughout endemic infectious diseases. It is this base degree of natural immunity that protects against the severe consequence of infections.
Thank you very much, Prof Teo, for your very informative discussion. We've exceeded the time limit, so Rotarian President Luis, over to you.
Thank you very much, Dr. Rupesh, for moderating this, and Professor Teo for this very, informative session. My question was not asked though. My question was, for those who can't afford to pay, will the Medifund be used, or will we penalize, those people who refuse to be vaxxed? Because I have to make that decision whether to approve that fund.
I believe the free AMs will still be available to support COVID-19 hospitalizations. And in fact, the news, despite the headline focusing on 25,000, it is important to highlight that that is for people who will experience ICU and intensive care. And that is before subsidy. In reality, the bill size that was talked about was between 2,000 to 4,000, of which MediSave can be used. MediShield and Medifund will still come in to help as well. Yes. So the free AMP and the subsidies, which has been the hallmark of Singapore's healthcare financing, still exist to look after these people. And that is exactly why I mentioned that it is the same way that we are treating as if people who are ill from smoking, from obesity, from unsafe behavior that people take up voluntarily.
Thank you very much. And thank you again for joining us. Thank you, Dr. Suresh, for moderating. And I would like to ask Dr. Ho Sek Tian to officially give you the vote of thanks. Dr. Ho, please.
Thank you, President Lim. It has been the most insightful session by Professor Teo. It is a difficult topic, one filled with complexities of issues, as has been highlighted by Professor Teo. At the end of the day, we can all agree that we want to move out of this crisis as painlessly as possible and be fair and principled at the same time. In this lies a balance. It is a balance that will have to continue to pursue. Before we thank Professor Teo with rapturous applause, let us first take some time to first unmute ourselves. Let's all unmute ourselves and do this in unison. Please take a few seconds, unmute yourself. Okay, then unmute yourself, Francisco. Unmute yourself, yeah. So let's do this all in unison, and on my signal, we all will thank in the usual manner. Thank you, Professor Teo.
Thank you. Thank you.
Thank you very much. Wonderful evening.
Thank you, Dr. Ho. And now for the last piece of our segment. All right, so Dr. Ho has given a vote of thanks. And just to talk about next week, we have from FRCS, which is the Foundation of Rotary Club Singapore, Mr. Dinesh Singh joining us to tell us more about the foundation and what you as Rotarians can do with the foundation. Okay, some of you are not familiar, but the Foundation of Rotary Clubs of Singapore includes all the members in Singapore, as in the different clubs in Singapore. So with that, we come to the end of our evening. It has been most insightful, and I'd like to thank all the interactors, all the guests, all the spouse that has joined us, all the past presidents who has taken time to join us. Thank you very much, and that leaves me to ring the bell and say good night.